What a nice day to be together, all together on Zoom on this nice, cold, rainy November 1st, Eastern Standard Time day. Good afternoon, and welcome to today's webinar, Putting Together Your PDA Team. I'm Susan Lust, Director of PWP, the Parkinson's Wellness Project. We are driven to bring you informative, inspiring, educational events for both people with Parkinson's and their families and their friends. This is the fifth webinar in our series, and we see from the great responses we're having that our virtual events are here to stay. We're now in the planning stages for the coming year, in which we will hopefully be having many more inspiring webinars for 2021. And if you know someone with PD, please tell them about us. Not everyone wants to seek us out themselves, and they need a little push from a caring friend. Hopefully, once we get back to congregating together safely, our live in person events will be back. Meanwhile, so many people are enjoying our virtual events from home and without the hassle of traveling. We are building a following of people who are committed to growing and learning, and I appreciate our audience so much. I know a lot of you, and I'm so glad that you're here today because you are all choosing life and planting seeds for living better. Now, I want to thank everyone on our team behind the scenes working together to make this webinar possible today. And it is our terrific sponsors for whom I learned so much, who are here today supporting our community. You will see the links. Um, you will see the links of all our sponsors with their logos. The links are under the name. And it's very important that you take the time to visit those sites, learn more about our sponsors, about their medications, about their therapies. So when you go to your doctor, you're more informed and you're more educated, and you'll be a part of your own healing with your doctor. So right now, I would like to say a big thank you. Although you can't see our attendees, we do have a lot of attendees here with us today, and our sponsors are with us. And although you can't see them, I would like to say a personal thank you to them. I would like to thank AbbVie. I'd like to thank Scott from AbbVie. I'd also like to thank from Acadia, Francesca. And from Accorda, I want to thank Elizabeth and Brenda. From Adamas, I want to thank Joe. From Boston Scientific, I want to thank Layla and Brandon. From Kiowa, Kieran, I want to thank Mike and Kimberly. From Lundbeck, thank you to Todd and Charisse. And Jenna from Medtronic. And Allison and Bill from Supernus. Thank you to all of you. Now, as we begin our program, we're beginning with the PDA team. And I would like to introduce you to Dr. Michael Rizak. Dr. Rizak, you have been guiding us every step of the way, and we appreciate your knowledge, your warmth, your passion, and I want to thank you with a lot of your patients who are here today for everything you're doing for us. Michael Rizak, doctor, researcher, and professor with a master's in psychology and a PhD in brain anatomy, is currently the director of the Movement Disorder Center of Nuvance Health at the Vassar Brothers Medical Center. Please welcome, drumroll, Dr. Michael Rizak and his A team.
Thank you, Susan. Thank you. I mean, I think much of the credit should be going to you. Oh, I like it. I love it. That was very clever. I can be Mr. T for a while, but I think a lot of the credit needs to go to Susan Lust, who she is a dynamo. She doesn't give up, and she is creative and makes things happen in the face of so many obstacles that she is really a miraculous individual. But today we're going to talk about the A team and what does that mean? It means that we need experts in many areas to be able to give our patients with Parkinson's disease the best care possible. Because Parkinson's is so multifactorial, it isn't just about the movement, and it isn't just about the neurology. It's about psychiatry, psychology, urology, ophthalmology, and many other areas. So it really becomes important to have the right people, the experts in the area on your team. And we can't expect the neurologist to be able to do everything that might come about as a result of the Parkinson's, but we do want to have educated physicians and others who can do the job and know a lot about Parkinson's disease. And today on our panel, we have three great people who I've known for a long time, very lucky to have known them and to work with them. And I'm going to start with my partner, both in Chicago as well as here, Dr. Jennifer Pallone. She's a movement disorders neurologist. She's been doing this for 25 years. And she treats really all kinds of movement disorders, but especially Parkinson's disease. And she's a one of a kind, not because she's my partner here at Vassar, but she takes the time. I often wish I could be as patient as she is, really learns about our patients, not just medically, but psychosocially, and family relations and all kinds of things. And she digs in to try to help. And she goes the extra mile. Dr. Pallone was practicing with me in Chicago for, at least 10 years or so, but I've known her for a long time, and we're very lucky to have her come and join me here at Vassar so we can give our patients the best comprehensive care possible. The next person, actually two, because we have two pictures up, Dr. Michael Mercury. First, I will introduce him. He's a neuropsychologist without comparison. I've known him for, God knows, probably 20 years or more, and we've worked together at several hospitals. He is such a mensch that you really don't see this in many people, but he also takes a personal interest in all of the patients that he sees, and he's an active team member in helping all of us understand what's going on with our patients emotionally, intellectually, psychologically. And he is really, again, wish we had a Michael Mercury right here at Vassar, but he's close enough that I can call him and ask him all kinds of questions and drive him a little mashuggy, but he doesn't complain. The other person who is, again, such a resource and wonderful person is Debbie Crystal. She's a social worker. She does psychotherapy. She helps our patients find resources. She has immense patience, can listen, can dig in, and can find ways of helping people on many levels, especially the emotional level. And she understands Parkinson's disease and all of the ramifications that go with it in terms of families, as well as emotional things that can occur in I used to call on her every time I saw a tear in anybody's eye, and she was always there to help me. And I learned a lot from her as well. So these are our team members for the panel today. But these are the kinds of people we want to have on our team. Be able to be interested in the patient personally, as well as professionally, and go beyond just the medical aspect of the disease, because as we know, Parkinson's disease is not only medical. There are many non-motor and emotional aspects that we want to deal with. So I'm going to start by giving you a vignette about a patient that we've encountered. And then I'm going to hear from the panel and see what they think. You know, how would they handle this? What advice would they give us? Is that okay with everybody? Okay. So this patient is a 65-year-old man. He had Parkinson's disease for about 10 years, maybe a little longer. And he comes to the office with his wife for a visit. And there we are. He really has no other past medical history that we have to worry about, but he hasn't gone to his primary care doctor for a checkup in over a year. And that's not something we're happy about, but we'll talk about that. His medicines at this point are carbidopa, levodopa, or Sinemet, 25/100, 1.5 tablets every 3 hours. And that's really working pretty well without side effects, as far as we know, to manage his motor symptoms. So his movement and his tremors and stiffness are pretty well controlled with that regimen alone. And today they come in with a number of questions and concerns. And I'll just list them, and then we can do a round robin and see what everybody thinks. The complaint really coming from his wife is that he seems tired all the time and has become very sedentary, would much prefer to sit and watch television than get up and do anything. And but he's not excessively sleepy. He just doesn't want to get up and do any physical activity. There's a lack of interest in activities, including exercise, hobbies, social gatherings, even family events. He doesn't want to go to a grandchild's birthday, for example, for no good reason. And when the events occur, he seems disengaged. If he does go, he doesn't really get into it, doesn't really feel it, and doesn't really join into any conversations. And so the family's worried about him. His wife thinks he might be depressed, but he says no, he's not depressed. His memory is not as sharp as it used to be, but he is independent in all his activities of daily living. He can take a shower, brush his teeth, get dressed all by himself. His wife is frustrated. She's probably on the verge of burning out, but she's frustrated with his lack of motivation. He's got no pep, no interest in participating in life. And she's worried. She's anxious and tearful while he is calm in the office. So when she's talking about this, you can tell her that she's really affected by this and is hurt. I mean, in some ways, maybe even taking some of it personally because she's trying so hard. And this is not an unusual scenario. It's very typical. Not very typical, but it occurs often. And I just wonder how, I'll start with Dr. Pallone and get her take on this as a neurologist.
Thank you, Dr. Rezac. I'm not sure if they're going to put me on the screen, if you can see me or not for the panel. When I hear this scenario, I think the first thing that concerns me is the lack of medical checkup. We'll start with that. There's many things that could be causing a person to be overly tired, disinterested, not feel well, be fatigued, not have any energy, and even not feel like their memory is as good as it used to be, that are not directly related to having Parkinson's disease, but certainly certain medical problems could be exacerbating some Parkinson's symptoms. And in addition to that, it's so important to take care of the whole body and the brain with attention to medical problems. If a person doesn't know they're diabetic, for example, getting attention to that is very important for brain health. So we have to take that seriously. There's a variety of concerns that a neurologist very commonly we will have about people that we take care of, including that they might have a low thyroid, they might have low vitamin levels, particularly B12, and even there's more attention now to vitamin D being too low and the ramifications of that. So I think the person that is coming to us with their family member and all these concerns, they really do need a general medical checkup. And an annual wellness visit is important for everyone, but particularly under these circumstances. What could be going on medically that could be easily reversible, treatable, manageable in a different way than we might manage with Parkinson's alone? In addition to that, as I hear this scenario, there's a variety of things that come to my mind. And one also is within Parkinson's patients, they might have sleepiness. They're not recognizing that. There's actually evidence that chronic sleepiness is not necessarily recognized by a person as being sleepy. And so we can in the office do some scoring. We call it Epworth Sleepiness Scale to determine just how sleepy might someone be and when they don't recognize it. There's another scale we can use called the Fatigue Severity Scale. And we can also use that to tell the difference between sleepiness and fatigue, because sleepiness, again, there can be a variety of reasons for that, but it is treatable. Fatigue is a non-motor symptom of Parkinson's that causes people to be limited in what they feel like doing. They just are kind of overwhelmed mentally with tasks and challenges. And so they, with the fatigue, they just don't have the energy to get started or do things. There's also something we refer to as apathy, which is I think we can get maybe a comment from Dr. Mercury about what the underpinnings are of that, but there's some thoughts that that's actually a cognitive problem to have apathy and lack of interest when there's really truly no other reason to not feel like doing things or not be interested in things. And then also with the testing that Dr. Mercury provides, we get an idea about the emotional state of the people that we're taking care of. Truly, are they depressed and just in denial, not recognizing that? Because that has a huge impact, of course, on mental energy, physical energy. So I would look at this from a lot of angles, I guess. And to start with, I would certainly recommend that a person have an annual wellness checkup, gets blood work. I'll even sometimes say to them what specifically I might be looking for. Interestingly, vitamin B12 used to be a very popular vitamin to get tested, and it's gone by the wayside. Now it seems like everybody gets a vitamin D level, but they don't get their B12 level. So that would be something I usually will suggest, that I want to know what their thyroid's like. I want to know what their B12 level's like, as well as their general chemistries, and make sure they're not anemic, etc. So all of that would be something I would recommend. And then in addition, I think a really important starting point is to actually refer a patient to get in-depth neurocognitive and psychological testing completed. And I'll be turning that over to Dr. Mercury to tell us a little more about what we can glean from that, including strengths, weaknesses, things that we need to be attending to that we don't know about yet, or just digging into the whole brain details and performance in a way that'll really help everybody. Because ultimately, too, when we engage our licensed clinical social worker, Debbie Crystal, I think that everything that we know medically and neuropsychologically, cognitively, really plays into how we can help. How can we approach this? What are the needs of both the patient, the person with Parkinson's disease, and then also their spouse, to have a better understanding of what's going on and better coping for both of them. And then I want to mention one more thing that I didn't bring up, and that's look at the whole medication list. And that's prescription and non-prescription, because people may forget sometimes the things that they might be taking. to help them sleep or throughout the day for pain or whatever the case may be that they're not necessarily complete, having on their list. And we want to know all of that. I will often say that I need to wrap my mind around the person. And that includes their health, their medicines, their social situation, strengths and weaknesses. So I'll leave it at that. I really think that the additional information that we can gather from all of those angles can make a big difference in this situation. I believe it's manageable, treatable.
Okay, thank you. I think we'll ask Dr. Mercury for his take on this and his suggestions.
Thanks, Dr. Rezac, and thank you, Dr. Pallone, for your excellent, really, I would say, summary of the difficulties the patient is having. And I totally agree. I think the physical is so important. Even when we look at a neuropsychological evaluation, I need to know, for example, does the patient have a hearing problem? And sometimes people do, and it's mild relatively, and they're 65, so what do you expect? And they don't even ask the doctor about that. So unless the doctor specifically asks about certain symptoms, they might not get an answer, or they might not have a patient who realizes how important that might be. If I have a slight hearing loss and I'm at a family gathering and I can't really hear what you're saying, and I'm kind of nodding politely, and I'm still stuck on that word from the third sentence before, after a while, you're going to stop talking to me because I'm not interested. I don't look like I'm interested, and I can become isolative because I'm not really engaging. So apathy could be one problem, but it could be I have hearing loss. So I think the physical is so important, and I think that annual wellness exam is helpful. But at the same time, I think if the spouse or other caregiver is noticing physical problems, it's important to bring that up to the doctor, because the patient might be overwhelmed, or they might not know that that's important. It might not bring up a physical symptom. So I think very, very important. Same thing with sleep. We know that 1 in 3 Americans has a sleep disorder if you include insomnia, and 2 out of 3 people with Parkinson's have a sleep disorder. So twice as common in Parkinson's disease. And again, people might not ask about that. The doctor might not ask about that. So we need to be proactive and well educated to do that. Neuropsychology is another area that's important. And in neuropsychology, we look at the cognitive domain. So what's going on with executive functioning? So that's judgment, organization, decision-making, planning, and so on. What's going on with language, word finding problems? What's going on with visual spatial? So when I'm driving, being sensitive to how close or how far something is, and what's going on with memory. And there are changes we can see in Parkinson's disease that can interfere with our daily lives. One of the things I believe I see more often than not is changes in executive functioning early on in the disease. So we've all had patients who've come in and we see them, as in this case, maybe 10 years into the diagnosis, and we find out that 5 years ago they were fired from their job. And I had one salesperson, for example, and he said, well, I went from being able to do 10 projects to only being able to manage 5 projects a year. And my boss thought I was lazy. Well, he wasn't lazy, but slowed processing of information, which is an executive functioning, speed of processing information, very common in Parkinson's disease. And in my opinion, early on can be common. And unless I, as a patient, am aware of that, the primary care physician's not going to necessarily ask about that. So that's something we'd want to be aware of and to bring up and just see, is it taking longer to do the checkbook? Are the calculations that we do in our head taking longer to do? That's really important. Being aware of the type of memory challenges a person might have. So very common is what we call a retrieval memory problem, where I have trouble recalling something. So you ask me, where did I go 3 days ago for dinner? And I say, I don't remember, I forgot. Well, technically, I didn't really forget. If you give me some extra time, it'll probably come to me. Or if you say, well, remember you said you drove a half an hour and it wasn't worth it. And I go, oh, that's right, I went to. So problems with memory can be disturbing to people, both to the patient and to the caregiver. And just being aware that usually it's a recall problem. So Post-it notes are going to help, other reminders, timers, using your smartphone, for when you're supposed to take your medications, things like that can be very, very helpful. So using technology as needed. And then the third aspect that I want to really emphasize is that this affects the whole family. And that's really important. So sometimes we'll see two patients who are doing equally, their Parkinson's is the physical symptoms are equal, but they're doing differently as far as how they're coping with it. And that's really where someone like our social worker, Debbie Crystal, comes in, because it's the patient's reaction to a chronic disease, it's the family's reaction to a chronic disease, and all those things have to be taken into account. So I'm going to switch over now to Debbie and have her give us her perspective on the case.
Mike, I want to ask you very briefly, let's say we do find some abnormalities on your testing, what would be the next, what would you do, or how would you handle that?
Excellent question. So the first thing I always tell patients is we look for modifiable or reversible factors. And that's where having a team, so my working with you or with Dr. Pallone becomes important. Is the vitamin B12 something that is low and it's in the process of being treated? Is there a sleep disorder? And we know with sleep disorders, for example, with sleep apnea, once we start somebody on CPAP, it's going to take about 3 months before cognitively the brain will benefit from that. So the first thing I would do would look to both of you, and ask what sort of physical problems are going on that might be contributing to the cognitive problems. Hearing loss would be another thing. Glasses that I last got 5 years ago might be another issue. And so I would look for all of those factors. That would be number one. Number two, I look at what can I do in the environment. How can I set up a routine? How can I set up the environment so that it works towards my strengths rather than towards my weaknesses? And then third is going back to technology, my peripheral brain here. How can I set this up? Or if I'm not real good with a smartphone, how can my adult children set up my smartphone so that the alarms go off when they should? And, or maybe we use an Alexa or something like that, that might even say, take your pills, it's time for your pills, and that sort of thing. So kind of a three-prong approach.
Okay. All right, well, thank you, thanks.
May I make a comment?
Of course.
Sorry.
Brief one.
And this goes back to something that Dr. Mercury and I have discussed before, and just want to make this point. If a person does have other medical problems, and especially if they've recently been ill, it is not the time for people to get testing, although they will be worse, and everyone's going to get worried about what that means. But just as treating the sleep apnea takes time for the brain to improve, if a person has been ill and they've had a setback cognitively, emotionally, as well as physically, that needs to be allowed to have time to recover before you're tested.
Now, that's a good point. And that also brings up something I didn't mention, and that's the bane of my existence, which is Tylenol PM, Advil PM, Bayer nighttime, anything with an antihistamine in it, which is used as an over-the-counter sleep aid. And usually you'll see diphenhydramine, which is the scientific name for Benadryl. And what does Benadryl as a nightly sleep drug do? It just causes constipation, confusion, and increased risk of falling. Very important. There's 3 things that we can reverse potentially. And so what I do with medications, Dr. Pallone, is I tell people, open your medicine cabinet, get a big plastic bag, and put everything in there so that I can literally do the shake test. So if this was a 1-month supply that was filled in March and it's still got pills in it, we know you're not taking your medications. I can look for expired medications, and equally importantly, to the point you had made earlier, I can also look for over-the-counter medications that might actually be harmful for the patient.
Okay, thank you. Thanks, both of you. I want to move on and get our social worker, our psychotherapist's take on this. Before I do that, though, I did fail to mention that Debbie Crystal is a Bostonian and actually went to school in New York. She went to Hunter College, School of Social Work, City University of New York to get her social work degree. And I think she spent some time here, but luckily she moved to the Midwest, at least for the Midwesterners, and she's there now. So Debbie, with all this stuff, and including the last, with the burnout maybe of the wife and feeling helpless, how do you counsel people with this?
So this is sort of a very familiar, I see many couples. So it's not an unusual scenario. And there are different pieces to it, right? Because need to think about depression. And depression occurs with people with Parkinson's disease, and like 40 to 50% of people with Parkinson's disease. And sometimes it's a reaction to what's going on. And maybe the wife and the person with Parkinson's disease are getting into it, but maybe it's just part of the disease process. And that's going to be an important piece to tease out. And the team will have to work together to sort of, with the person with Parkinson's disease, to sort of figure that one out. I do think that the executive impairment is also an issue. And so between depression, which can sometimes cause executive impairment, and the organizational, and also just having Parkinson's disease, sometimes it's hard to sort of figure out, what to do and what makes the most sense. But then if you have a spouse who's sort of very worried, and saying you should do this and you should do that, then often the person with Parkinson's disease is sort of shutting down as well. And so it sort of gets complicated, and it's a matter of sort of figuring it out. I often, as what Dr. Mercury said, figuring out compensatory strategies. So maybe having a class for exercise where you're just there, and virtual exercise classes right now in some ways is easier. You don't have to get to a class. I mean, it's not quite the same. But people are really enjoying these classes and feeling less isolated, which can help with depression. So, I mean, I would encourage the person with Parkinson's disease to figure out what kind of exercise or some sort of, or support group or something that would be meaningful, and figuring out a strategy to make that happen so that the spouse isn't always so panicked. I always worry about, I always talk about Parkinson's disease as a family disease. And so it's impacting adult children, spouses. And so I would worry about the spouse and caregiver burden. Sometimes the person with Parkinson's disease will say, my wife is always yelling at me. And then the spouse will say, yeah, I am always yelling at them because I want them to do X, Y, and Z. And so to sort of like look at that dynamic and figuring out something that would be more helpful to both of them, so that they can feel more successful. It's interesting. The Parkinson's Foundation has said that the non-motor diseases, the non-motor symptoms of Parkinson's disease actually impact quality of life much more than the motor. And so that's when I don't know who said it, but the fact that you could have two people who have the same symptoms, but it's the non-motor symptoms that really may, and depression, apathy, executive impairment. Those are all kinds of things that can really impact quality of life and can really be fixed. Depression also, a lot of our patients will end up with some medication, and often Dr. Pallone, Dr. Rezac, or some other neurologist or primary care physician or psychiatrist can prescribe that.
Okay. Just a couple of, see how we're doing on time. I think we're okay, but Debbie, I often, this is something that we see where a spouse is thinking that the patient is doing some of these, that they can't do things, and it's sort of passive aggressive
Yes.
toward them, and they take it very personally, when it may not be. I mean, what would you advise for that?
Well, and so, we do quite a bit of couples therapy. And I would say sometimes there is some passive aggressive, because the person with Parkinson's disease just, the last thing you want on top of everything, it's for somebody to say, and that's not true of all of our patients, but that could be true of a subset. But sometimes, the person with Parkinson's disease, they have a more flat affect, and the person with the family member may think that that means that the person's not listening or not responding, and it's more the affect is different, but that they are absorbing that information. But then things may escalate in any case. And sometimes it's really, it's the person with Parkinson's disease just very frustrated with themselves, and it has nothing at all to do with the spouse. So it's sometimes a little investigative work.
And you discuss these things when you meet and do therapy, and
Yes.
it's important because it really brings these issues up to the surface and out in the open, so that can be discussed. Otherwise, it kind of remains under the surface, and the anger starts boiling up and frustration. And I think, you're a gift to our patients. So thank you for doing that.
Yeah, I guess, and the other thing is that I normalize it.
Okay. What does that?
And I think that that's really important. So this is not, just this awful thing. And if a spouse is yelling, it's not an awful thing. And, that these are things happen. And so what could be changed? What could be different? Thank you.
All right,
Debbie, I
great.
think that also brings up the excellent point that if you're going to see a psychotherapist or a social worker, you need someone who is familiar with movement disorders with Parkinson's disease, because the clinician might mistake a flat affect as being something different than the masking of the face that we can see with Parkinson's. So you need someone who's well informed, and that makes it a challenge, I believe, for getting the appropriate help as well.
And I would say that it's, I sometimes get, I think that anybody can feel that way. And so, and certainly those are, I don't think there are enough social workers, therapists who have that expertise, but certainly you can share that with a therapist, or they can read up on it. But it is a thing.
Okay. Any other comments from any of the other panel members? Dr. Pallone, Dr. Mercury? I would ask Dr. Pallone, when we do find patients with, let's say, some memory problems, short-term memory problems, or they're getting, they're really truly forgetting, Dr. Mercury verifies that on his neuropsych testing. What can be done about that medically? Is there something that can be done to help patients with memory problems?
Yes, I would first say, kind of goes back to making sure medically the people are healthy. I think that's probably first and foremost. And looking at medications, let's make sure there's not something that's offending the thinking, and try to adjust there if it's at all possible. Also, there's evidence that low blood pressure, which Parkinson's patients are a little more likely to develop throughout their condition. So they may be having cognitive problems because their blood pressure is now too low. So sometimes we'll be have people, the family, actually, and the patient take measurements at home. So looking at all of that. However, let's say we've maximized medically what they can do. Oh, and exercise. Did I say that yet? Exercise helps so many things. If a person has done all of that, then there is actually prescription medication that we use for improving cognition in Parkinson's patients. They were both originally, actually there's 3 of them, but they were originally medications that were used for Alzheimer's disease. And as Dr. Mercury alluded to a little bit earlier, these medicines raise a chemical in your brain called acetylcholine, which brings us back to one other comment, and that's there's a lot of neurotransmitters that are changed in the brain with Parkinson's, not just dopamine, which is what we talk about all the time, but there are other neurotransmitters that are affected. And so balancing out those neurotransmitters can help people. Increasing acetylcholine levels does help with Parkinson's, and there's actually one medication in particular that is FDA approved for use in Parkinson's patients. Its generic name is rivastigmine, but the brand name was Exelon. It comes in capsules and it also comes in a patch. And I have clearly seen improvement in patients when they are on these medications. There's another one I also use very commonly called donepezil. Brand name was Aricept. And occasionally I might use memantine, brand name is Namenda. So we can improve on brain chemistry, and looking at using those medications is definitely an option. Once we know more about what all it is actually transpiring, then we can turn to a lot of things that can be managed and also prescriptions that can be given. And in addition, possibly antidepressants might be used, because if a person is significantly depressed, we know that anxiety, that depression really inhibits good cognitive processing.
Dr. Rizek, I think we have time for one more question, and there is a question in the chat.
Yeah, so I would steer this chat question to Debbie and Michael Mercury, and I'll read it to you. It says, instead of using in quotes, you should do, or in quotes, you are quite able to do this and that, statements by the caretaker to the Parkinson's partner, what other words or phrases would be better to use to reflect more patience, more understanding, and less frustration? I believe in we affinity, but not sure how to get through to my wife with Parkinson's, what to say in a better, I guess, better way to have the patient understand that it's really for their best interests. Does that make sense?
Yeah, I mean, I'm happy to address, I think every caregiver has to find the right words that might work, or the right person who may be able to communicate that, if that makes any sense. I also am very cognizant that the caregiver really needs to be taking care of themselves. And that really makes a difference in their patience level. It's just a thing. And so that more that you can take care of yourself, the caregiver, than when you address and you say, oh, let's do this, not do you want to do it, or you should do this, but, or I found this something that seems very interesting, or do you want to do this or that? There's different ways that different couples figure out to communicate, but it's also making sure the caregiver is doing a lot of self-care.
Great. All right. Thank you. Mike, do you have anything to add?
I think that's perfect. I totally agree with what Debbie said.
All right, great. Okay, so I think we're going to end this segment. I'm going to have Susan come in and help me do that. And I think the panel was excellent ideas and excellent insight into these common problems that are really not necessarily related to the movement, but they are part of Parkinson's disease. And we know Parkinson's is a global systemic really illness, and we need to address all of the issues as they arise. So I'll end it there. And Susan, I'll have you take
Yeah.
over.
Yes, I want to thank you, A team. I think it's the A+ team.
Yeah.
So thank you very much. And we're going to have a little musical interlude right now. So
Come on.
everybody stay with us. We're going to introduce you to Arlen Bennett. He's going to play a song of his that he's a good friend, a wonderful poet, singer, songwriter, and we got to wish him well because he just told me that he not feeling so well. He broke his rib, so we got to hope that he heals quickly so he can play guitar for us the next time. But right now we have a recording for him. So grab some water, everybody, take a little stretch and enjoy Arlen. And we'll be back with.
Hi, this is Arlen Bennett with the Healing Project. Thanks for stopping in. This is called Don't Turn Back Now. It's on my new release EP that's out there by the same title, The Healing Project. It's actually an old song of mine, but I resurrected it because I didn't want to turn back. It's called Don't Turn Back Now. Reach inside your mind, find the dream you thought about for a long, long time, and climb that mountain that you always said you could, the one you always said you would. Reach inside your pocket, find the change you said that you always make, and take the chances that you've been afraid to take. Fear will be your worst mistake. Don't turn back now. Don't turn back now. Dreams are there for the making. Don't turn back now. Don't turn back now. Stars are there for the taking. If you can see through the clouds, now reach inside your heart. Find the peace you lost when it broke apart. And start to play the games that children often do. There's still a child in you. Don't turn back now. Don't turn back now. Dreams are there for the making. Don't turn back now. Don't turn back now. Stars are there for the taking. If you can see through the clouds, who else can you rely on? Who else will make it so? There's just one dream to keep your eye on. Until you do, you'll never know. So reach up on the shelf. Amongst the dust up there, you just might find yourself. And leave the fingerprints for someone else to find.
I sent them a video of Don't Turn Back. That was, I just kind of did it off the cuff and they're just using that. Here's Lane. Yeah.
Thank you, Arlen. And hope to see you soon. I know that that is an expression of gratitude to your own family as well. So having a challenge such as Parkinson's brings those who care for you to your side, and we cherish their presence and their closeness. A challenge can easily unravel the threads of a marriage or a family, but when a family works together to encourage and support each other, the relationships can reach great heights. So join me in welcoming our families who have attained those heights. I want to introduce you and welcome to some friends of mine who I've known over the last couple of
Alexis got the COVID.
and I would like to invite all the attendees to mute themselves so we don't hear all of you, so everybody can hear the panelists better. And then I also want to say any questions that you have that we do not get answered on this webinar, we will write them on the, we will get the answers from our A team and put them on the blog. So right now, I'd like to introduce you to Anita. Anita is a good friend and a wonderful wife and mother. And I'd like to introduce you to the two sisters, Rachel and Hannah. And turn on your sound, everybody. And I'd like to introduce you to Rena. They are joining our doctors today, and we'll have them all together talking. And I'd like to turn this over to Dr. Rizak, and I know you're going to introduce them. They'll introduce themselves.
Okay, great. I really appreciate actual family members being here and discussing some of the questions and difficulties they have in coping and dealing with the Parkinson's patient. I think what we'll do is we will do a round robin in terms of introduction. Why don't we, and then I'll come back and we can ask various questions. If Anita is there, why don't we start with Anita?
Hi, I'm Anita Sato. My husband Henry and I married for 45 years. During this time, he's beaten cancer twice and a lung disease, and was diagnosed with Parkinson's in July of 2019. And this seems to be the one that there's no beating. So that's the challenge here.
Okay, thank you. Rachel and Hannah, are you on the air here?
Yes, we are. Hi. Hi, Dr. Rizak.
Tell us about what's going on with you.
So we're here today to support our dad with Parkinson's. Our dad was diagnosed with having Parkinsonian features, I would say about
4 or 5 years ago.
About 4 or 5 years ago, but never really, it was just the Parkinsonian features. He never had like a full Parkinson diagnosis until I would say closer to a year ago, after intensive testing done through Dr. Rizak. He also comes with a host of other medical conditions. He has been ill with a different autoimmune disease, totally separate from Parkinson's, for the past 20 years plus, 25. So he's really coming in to this, to Parkinson's after really kind of been ill for a long time with a lot of different medical needs. And while his previous conditions also have not necessarily been beatable, at times they have gone more into like remission-like stages. And we are also, similarly to what Anita said, kind of confronting this kind of thing where there's no remission stages. This is something chronic.
Okay. Thank you for sharing. Rena?
Hi, I'm Rena Shakowitz. My dad was diagnosed with Parkinson's in 2007. He was 52 years old. He had DBS implanted 6 years ago. He's a real fighter. He's very optimistic. He spends a lot of time studying the achievement of strength through adversity. He doesn't like to bother people with his illness or cause pain to other people or to be a burden. He likes to be the giver. He's always looking to try new modalities to improve his Parkinson's symptoms. He's tried Theracycle, different exercise and strengthening, different supplements. He's usually independent with his activities of daily living, but without warning, he'll experience worsening of symptoms where he can't walk or has difficulty moving, opening pill bottles, preparing meals. And his setbacks seem to be associated with colds, changes in meds, or sometimes just unexplainable. His support system includes his immediate family, and his kids and their spouses. Everyone helps in their own way.
Okay. I think we've got everybody. So Rena, as long as you're on. Why don't we start? We're going to go through everybody and ask one question. We got to keep it sort of concise. And then we'll see what the panel has to say. So if you had to ask us a question or something that you were having trouble coping or dealing with, what would it be?
Do you have any suggestions as to how we can deal with variations of symptoms or setbacks, either during each day or over time, when it seems unpredictable? One day he'll be doing great and the next day, boom, he needs help and he can't do anything.
Okay, I think this one might be, first we could ask Dr. Pallone. We'll talk about this from a neurology standpoint, but then we'll talk about it maybe as well from an emotional standpoint, because it's not easy seeing the fluctuations like that. So Dr. Pallone?
Yeah, that it's definitely a complicated issue to look at. And the best way the way I guide people is to create a log. So I give them kind of homework to do. There usually is a pattern in there that maybe we can discern, we can tease out that isn't obvious. And looking at when the symptoms occurred, like you said, sometimes it's explainable because they did have an illness, and that may make sense to everybody, but it could have something to do with their medication itself. And I'm not sure when you say that, is it a physical inability or is it actually more of a energy inability? So we would try to tease that out as well. What exactly do they feel limited by? And when do they feel it? What time of day do they feel it? And try to figure out if there's anything there that is a pattern. So oftentimes there's a pattern to it. We just have to figure that out. And maybe it is just psychologically tired. That could be. And so we would have to look into that and see if there's a way to help them pace themselves a little bit differently. Some people will push themselves too hard and then not have a lot of reserve. So then the next day they're too tired, or maybe several days, or they're not sleeping as well. So I would create a real questionnaire and a log to follow for that person to then bring back maybe, their next visit, or to fax it in or email it in, so that we can dig into it a little more and see what the patterns are and see what we can be doing about it. Because oftentimes there's something we can do if we know more about the symptoms and the when. So.
Thank you.
And what else is going on? Did they just have a big, turkey dinner, something, that is and sometimes it's meal related, sometimes there is sudden on and off episodes that occur, but we need to figure out if there's a pattern. We can adjust the pattern, we can make changes, and it can get better. But I'm sure it's disconcerting because 1 minute a patient is actually doing well and doing everything for themselves, and then 60 seconds later they're frozen, they can't move. And families, but especially others don't understand that it can happen in Parkinson's disease. There's a random acute motor fluctuations, and it's hard to cope with that, because if somebody decides to take a walk around the block and they're halfway around the block and suddenly they can't walk and they call for help, it's hard to understand. And I think it's something that it's not that unusual. So I'm going to ask Debbie or Mike to give us any input they have. Dr. Mercury and or Debbie.
So I actually, I think there are two pieces to this. And one of that is that it's again normalizing that sometimes, fluctuations happen in Parkinson's disease. That's just the reality. Not with everybody. And I always recognize that I see a subset of people. So the ones that may be struggling a little bit more. So that's part of what's going on. But I also encourage people, trying to figure out what is, but also to lean in a little bit and say, okay, this may be a problem. So if there's a problem, then, if you take a walk, maybe take a walk where you can sit, if you can sit, if you're freezing, but that I always tell people, and I don't know how the rest of the panelists feel about this, but I always say, you can't really power through Parkinson's disease. That there are better moments and worse moments, and sort of not fighting it as much actually often will help you fight it within the disease rather than outside.
Dr. Mercury, any added comments before we?
No, I have nothing to add. I thought the log is an excellent idea and Debbie's comments are excellent. I have nothing to add.
All right. I think it's Rachel and Hannah's turn to give us issues.
Hi, yes. So question, doctors say that Parkinson's is a family disease. Can you explain the meaning behind that and the need for families to be included in the process?
Dr. Mercury, you want to try that one?
Certainly. I think education is so important. So the family has to be knowledgeable about not only the patient's specific challenges, but also what is known about Parkinson's disease. And that helps in how they react to different things that the patient might do or might experience, such as we talked about earlier, the masking of the face. So sometimes looking disinterested when actually they might be very interested, they just can't show it so that that's not misinterpreted. So the family, how successful I believe a patient is with the disease depends to a certain extent on how the family also reacts to it. But I'd be interested in hearing what Debbie would say about this as well.
So I've basically worked mostly with people with neurologic disease of different kinds. So I can't, but I truly believe that all diseases to a certain extent, they impact everybody in the family. I'm not 100% sure, I can't say why, but I think the fact that it impacts the brain, so there's thinking involved and there's the motor stuff and there's behavior, that person, the person who has Parkinson's disease, that impacts them and it impacts the family members. I think that's why, but but I think anybody who has any sort of disease, nobody lives in isolation. I mean, maybe somebody does, but most of our patients don't live in isolation.
Dr. Pallone, what's your take on Parkinson's as a family affair?
I 100% agree with what has been said. It's very helpful when a family member comes with the person, or these days is in the virtual visit, so that we can get another view of what's happening. And it really is important. And I believe that including them is also very important, so that the anxiety level can be less for everybody. It certainly seems that anxiety within a household and within family members who really want to feel good being together, but that anxiety feeds off of each other. And then as a result of that, there's less closeness and more frustration. And then there's kind of a cascade of events and that domino effect that really is destructive. So keeping everybody in the loop, taking advantage of the talents of a licensed clinical social worker or a psychologist, I think is extremely important for everyone's well-being, because everyone's included in this. And that makes it actually better to bear for the person with the illness and for the family. So.
Thank you. I mean, I have a lot to say, but I do think that the one thing that's true is, at least with the families that I deal with, and I think that are on the panel today, there's a closeness that really, when something happens to one of our family members, when we're so close to them, it definitely affects us. And that, I think, is why it affects everybody. We have to change what we're doing. We can't go to the restaurant because we have to take care of the person with Parkinson's. Someone's got to be there. We got to help. So it really does, especially with very close families, I think, probably everybody, but close families for sure, it impacts them. Emotionally, it's hard to watch somebody with Parkinson's over the many years. There are lots of issues, but again, I'm treading on other people's expertise. So I'm going to stop there, and I'm going to now ask Anita to tell us some things that are going on with her.
I have a question actually about something you mentioned, because Henry and I were both interested in this. You had said that when selecting an ophthalmologist or a urologist, a specialist, that it should be someone who's familiar with PD. And this was interesting to us. We wanted to know, what are the particular interactions that PD has with, for example, your urinary tract or your vision and such to watch out for? And when we do find these doctors, who is the central lead physician on our team? Would it be our neurologist or our primary?
I'll start with that one. I think first, the neurologist can be I would say a movement disorders neurologist, if possible, is the best person to have involved in taking care of somebody with Parkinson's disease, because they have the familiarity and education and expertise. But the neurologist, so for myself, if somebody has a vision problem, which may be double vision, blurry vision, that has to do with the way the eyes align, sometimes that happens in Parkinson's, we want to send people to a neuro-ophthalmologist if possible. And in most major medical centers and some other community hospitals, there are neuro-ophthalmologists, and we try to find those and refer our patients to those people. There are neurourologists that have a lot of experience and sort of specialists. Not as many of those, but they're there. And most urologists are familiar with Parkinson patients. They just seem to see a lot of them, and it's the urinary tract, the urogenital tract, it can be affected not uncommonly with Parkinson's disease. So, your neurologist is a good resource for referring you if they're not able to manage things adequately themselves. And I think, there are a lot of subtle things that happen that can affect in many different areas of the body that can affect Parkinson's disease. And, sleep can be, of course, we talked about that a little bit, but sleep is a big deal in Parkinson's, and we may need a good sleep specialist. Could be a pulmonary doctor. Some of them have expertise in sleep disorders, and could be a neurologist. So they're available, they're out there. And the neurologist should know where they are and who they are and help with referrals. Any additions to that?
I would agree with that, because I think the other problem with our primary care physicians is often the limited time they have. So in the 15 minutes they have to look at heart, lungs, everything else, and they don't have the luxury of a longer visit that a movement disorder specialist would have. And so I think that's why really the movement disorder specialist does become key in making appropriate referrals for urology, for sleep, to people who are able to help with those problems.
Okay. I think I'm going to let Anita ask another question she has.
Well, it's interesting because you mentioned sleep. So my husband doesn't go into REM sleep, and actually this is something we're wondering if this was a pre-Parkinson's thing that just we're noticing more now. And he acts out his dreams. I mean, he will literally be all over the place, and my being there is I'm the person that gets the benefit of him acting out his dreams. And so, I know that this is not unusual, and I've heard of other people that had it, but what can we do about this? Is this, how do we manage it besides hunkering down at night? What?
So I'm going to let Dr. Pallone start with REM sleep behavior disorder and tell us what it is and what does it signify.
Thank you very much.
So REM behavior sleep disorder is actually occurring in REM sleep. So the person is in their dream state and they are, whatever it is they may be dreaming of, we normally only move our eyes, which is why that's REM, rapid eye movements, is the predominant movement that should occur. Occasionally we might all talk or move a little bit, and occasionally people kick and things. But in REM sleep behavior disorder, there's an actual more purposeful movement the grabbing of something, throwing something, acting like they're punching something. So it's a real directed movement, which is different from the usual, a flick of the arm or fingers or a kick in sleep. So when the neurologist, when we hear this, and actually sleep specialists as well, and some primary care doctors are aware that if that is what's occurring in sleep, if that's what's described, that it actually is linked to future of having Parkinson's disease and a few other disorders as well. So it is well known. It definitely is well known, and it can occur way before Parkinson's is physically diagnosed, and sometimes not right away. It may occur in the first year, and occasionally I've also had it occur a little bit later in the course. The first level of management is to determine how much of a problem it is. So it isn't always, occasionally it's mild and it's only occurring once every few weeks, and people will say, it's okay, well, we need to keep track of that. So every time they come back for a visit, we're going to ask about that. But an easy management actually is a supplement of melatonin.
Okay.
So the common dosing for me, and Dr. Rizak can say what he would use, but my common starting dose is 3 milligrams. So they take that before bed. And actually, I should even say this, now there are extended release forms, because REM sleep occurs in cycles through the night. And interestingly, in some people, it's been described more towards morning. And not necessarily in the first half of the night. So you might need an extended release melatonin that is easily available now, in the same places that you would find a melatonin supplement over the counter. And again, probably start with about 3 milligrams to help cover the night. That will, a lot of times, that is going to suppress this activity. The other, and Dr. Rizak, can comment, but there is prescription medication. For me, it's a second line, unless it's a really severe case, is using clonazepam, which is a prescription that can be used at bedtime. And that also can help through the night to suppress the movements. Dr. Rizak.
Well, I agree with you. I mean, I'm not a big melatonin fan, maybe because I haven't used it that much, but I use Klonopin or clonazepam frequently, very low dose we start with, and sometimes that's enough. When do we do it? If spouses are at risk for injury or have been injured, or patients can throw themselves out of bed, hit the edge of the dresser, and injure themselves. I think, we want to treat that. We don't want that to go away. It's not funny, it's serious. People can really injure themselves. I had one case not that long ago where the spouse woke up being choked by the patient, the husband, and he was sound asleep. He had no idea this was going on. She needed to go to the emergency room because he almost fractured her larynx. That was, of course, before I got to them. But a little treatment with clonazepam, and it can be very helpful. But it does make people, they don't get a restful sleep, and the next day they can be tired and schlep around, and you wonder why. And especially people that live alone don't even know that this is happening until they hurt themselves. So I know Dr. Mercury loves sleep issues, so I'm going to ask him if he has any comment on that.
And what I would add is, and what I think you've both been alluding to is I would look at the environment and make sure it's safe. So for the patient, make sure there's not a bed table with sharp corners where they could injure themselves. For the bed partner, sometimes a body pillow is enough to keep them safe. Sometimes though, even with treatment, it might mean having separate beds. So making sure both people are safe, looking at the environment. I had one patient who not only fell out of bed, but the bed was so close to the wall that they couldn't move out of there. They had trouble breathing because they were wedged in between the wall and the bed. So really looking at the environment is very, very important.
No, that's excellent. I mean, if we're not sure what's going on and we know, something is not right in the middle of the night, we can always have a formal overnight sleep study where the patient stays in the hospital and they videotape and record EEG and all kinds of things to see what is really going on at night. And sometimes, we don't know because we're not there and nobody sees it. And so that can be very helpful in that making a firm diagnosis. But when the story is what I just heard, I think we can just clinically, we know what it is and we need to treat it.
Thank you very much. I appreciate it.
Okay. All right, let's, yeah, I want to ask Debbie if she had anything to add before I move on.
No, that's great. Thank you.
Okay, we'll go back to Rena and see if she has another stumper for us.
Okay. My father's a real giver. He's been always, from when we were little, giving to the kids, driving them places, always there for us. But he has a hard time being on the receiving end. So how do we convince him to let us know, give us a heads up on when his symptoms turn for the worse, so we don't wait for it to find out when it's like at a dangerous level?
So we need a personality transplant. No, I'm kidding.
We don't want that.
I think I'm gonna, I don't know, I think I'm gonna ask Debbie on this one first, because she's got this insight. Yeah,
I mean, I think it is a bit of a challenge. I actually think that it can be a gift to our patients, to also to let family help. And sometimes even having that kind of conversation can be useful. But it is frustrating for our patients. And that's when I talk about the leaning in a little bit, that, you know, well, you may not be able to do this, or you may need sometimes to get help with that, but you also can still do this and that and the other thing. So it's not all or nothing. And sometimes just having that sort of conversation and acknowledging the frustration, but also all the good that he's still able to do for you guys, and what might you be able to do for him. Not bad. It's not a bad thing. And having that kind of conversation might be useful.
yeah, right,
you.
Michael.
Yeah, I completely agree. And I often tell patients, you know, it's easy to see what's giving us trouble or the weaknesses we have, and to miss the strengths, the gifts that we still have. So just to what Debbie said, helping patients identify what can they do successfully, how are they still givers? And then again, processing that whole idea of I can now receive things, and there can be gratitude for being able to do that. So just processing it with an appropriate person that they can talk with, whether it be family or whether it be a professional like a social worker.
Yeah, it's a way of giving is to receive, right?
True.
That's true. I think people have to understand that, who have been only givers and protectors and never allowed anybody to help them. I think it's a process, as you said, and it's communication and talking. And I'm going to ask Dr. Pallone. I know she sees this as well. What do you think?
In total agreement with Debbie. Yeah, and I think any of us can relate to this, actually, is that if we've led our lives being the ones that are people lean on, it's a real difficult transition to lean on someone else. So it does take, I think, some time to adjust and to bringing that out for conversation, as Debbie said, and get that conversation going sooner than later, I think is really important. And beings that they are a giver, they are a caretaker, one of the ways they can continue to take care of the family is to share the important things that are going on with them, so that it can be addressed before it's more of a concern or stress to those that love them. So.
And I always like the idea of asking the patient for advice, making them feel, you know, they're still taking care of everyone, and because, you know, that's what they want to do and that's who they are. And I think giving them scenarios of some issues that are going on in the family, you know, it doesn't have to be major things, but allow them to have their input, and they'll feel like they're really taken care of.
Dr. Rizak, I would add to that. One of the things I always emphasize neuropsychologically is this does not affect your IQ. So I think sometimes people feel like it does, or they feel dumb, and usually it's just that slow processing. It might take them longer to respond to a question. It might take them longer to plan something out, but it's not affecting their intelligence. And so I totally agree. Giving them the chance maybe the extra time that they need to be able to contribute to a family issue or to something like a celebration. Planning that might take them longer. You might need more patience, but letting them be part of it's so important.
That's excellent, yeah. Okay, I'm gonna move back to Rachel and Chana for any other questions they may have.
One last question, and then we'll move on to our chat, but this is great. One last question.
Okay,
So, I mean, one thing that I know that, you know, we keep hearing, both in this forum and in, you know, other forums, the Parkinson's can have a big effect on mood. Aside from, you know, not that anything about you know, giving medication, but not, you know, nothing to do with that. But aside from the medication, is there anything that can be done to help people with Parkinson's through, you know, that aspect of the disease to keep up, you know, previous levels of motivation and animation?
well, I mean, I think there are things, and I of course, I'm gonna talk about, I mean, I think we can talk about exercise. We can talk about getting those endorphin levels up and actually showing people that patients that by doing these things, they become more independent. They become more mobile. The little things mean a lot. So Dr. Pallone, I'll let you take it from there.
Right. There's so many factors in our health of our mood, if you will. And so being healthy, and talking to the neurologist about what things are maybe, you know, are there things that are particularly bothering them that they need to bring out, any concerns about how they're doing, and just ask questions. A lot of times that will help as well. And separate from medications, again, good sleep is extremely important for mood, for all of us, making sure that we are getting adequate sleep. And along that line, I will say that a lot of people with Parkinson's need more sleep than they used to. So figuring that out and making sure that that rest has been maximized. And then, of course, just looking at how can we be mentally stronger. And that is where we look at what can Dr. Mercury find out in his testing that's going to help direct what might be cognitively limiting that person. And then also to bring them to Debbie Crystal or a colleague such as that, so that we can, as the team, really maximize the physical and mental health. And it really does make a difference in improving mood. I absolutely think it's treatable.
I would just add, I don't think we should be afraid of adding a medication if it will help someone become a little more motivated, less depressed. I think a lot of people, you know, especially from the old school or parents, don't want to hear about psychiatric medications or other medicines like in that realm, but it can be helpful if it's the right problem at the right time. And that's what we have to think about. So in terms of non-medical things that can help Parkinson's patients do better, it's of course all the things we talked about, cognitive exercises, and I think physical exercises can make a huge difference. Physical therapy, speech therapy, those kinds of things are important. And I'm going to let Dr. Mercury, call him Mike because he's my friend, but formerly Dr. Mercury, let us know what you think.
I think the point that both of you are making is multifactorial. So number one, deciding what is the source. If it's a motivation problem, is it because of depression, or is it actually apathy? And apathy is really a tough one because we don't have a specific medication for apathy. So we're going to first of all find out, is it truly apathy, or is it related to sleep? Is it related to depression, and so on? So figuring that out, what's the source of it? And then if it's indeed something like apathy, we know that changing the environment can be helpful. But I'm going to actually shift over to Debbie Crystal, because psychotherapy is equally effective as medications. There's pros and cons to both, and sometimes we use a two-prong approach. So let me have Debbie address psychotherapy and how that can be successful in depression, anxiety, and so on. Debbie?
Well, so it's very interesting for me that so I was trained a very long time ago as a clinical social worker. But I've actually, particularly with, so psychotherapy, counseling, I do a lot of family counseling because I think that's really useful. But also, I've realized that a lot of the meditation, deep breathing, a lot of Tai Chi, that kind of stuff, which is not really, wasn't really my thing per se, has been really useful. People who, I recently was working with somebody who had like a dystonia or right in the middle when she was at a restaurant, and, you know, figuring out a strategy to really calm herself down, which made everything worse. And I think sometimes that's true with freezing, all kinds of things like that, that first there's that symptom and then there's anxiety about the symptom, which then makes everything more difficult. That learning to manage that with different, even just deep breathing, you know, counting to 4, breathe in for 4, hold for 4, breathe out for 4, stay still for 4, can really, really make a difference, and has made a difference for a number of my patients.
I think those are excellent suggestions. It brings to mind briefly one of my patients that had a gait freezing, which meant that they could be walking along nicely, then suddenly their feet just will not move and they're stuck. And not a fun thing when you're in line at a grocery store and people are waiting and you can't move. And anxiety about the people behind you, you know, this is what happened with this person. It would create the freezing episode to get worse. And we also know that pushing, I think Debbie, you may have mentioned this, but pushing through a freezing episode or some Parkinson's symptom that's very difficult can actually make it worse. You know, you actually exacerbate it. So training, like in the old days, we used to do alpha rhythms, but, you know, mantras or something that will relax somebody can break these episodic Parkinson's symptoms that appear and can be very difficult at times. So you're right. There's other training that can be done other than throwing medicine at people sometimes.
And Dr. Rizek, just one other comment on that. That's why we do need to draw out what's really bothering patients with their illness, because they don't always know how to describe what's happening. We know what might be happening. So we have very long questionnaires just to hit highlights of what might be occurring, so that that can bring that to the surface. You can really give them a voice and give them an opportunity to actually describe what it is that's really worrying them the most, whether it's motor, non-motor, or just long-term future.
That's why we need longer appointments, which we insisted on when we came to Vassar, that we have long appointments so that we don't have to rush our patients and we can listen. I mean, of course, the business of medicine now they don't like that, but we're still hanging on. But, you know, it's just the way of the world. We try to do that, but it is communication that makes the difference, because we understand what's really going on and we can make a difference in that regard.
And I know we're almost at the end, but along that point as well, write things down ahead of time. If you can encourage, you know, your loved one or whoever it may be, to the person who may be listening that has Parkinson's, write down your concerns before you get to your appointment. Because if you do feel rushed, you definitely won't have a chance to gather your thoughts and to put those questions down. So put them down, write them down. And if the doctor doesn't have time to address it, then maybe they can come, you know, give you that information at a later time. So.
Okay, well, before I throw this back to Susan, I'm gonna thank the families for coming on here, family members, and sharing this information, because it's real life. And it's not just a vignette that we read in a book. And so it really is helpful, I think, to everyone to hear that we're all struggling with this. And I have to say, my father had Parkinson's. I lived through it. And I was already a neurologist, but it still was very hard. As a family member, it was a whole different thing. So thank you all for sharing and opening up and letting us talk about this and finding helpful hints. Thank you.
Thank you for listening and your advice. Thank you very much.
Thank you. Susan?
I think what we're all learning from this is that we do need to get together with you professionals, and we do need to learn and talk about our situations that are going on, because it's an active, in the moment disease, ever changing all the time. And so as everybody comes up with their different situations, we need our go-to team. So we're working on a support system. Hopefully we'll have something in next year coming up. But I do want to thank everybody for joining us today. Did you want to say something, Dr. Riza?
I would like you to talk about the exercise classes that we have online, which are fantastic. I think people need to know that that's available to them. So I'll let you explain it quickly.
I will tell you. Parkinson's Wellness Project is running 6 hours of classes a week. Dance, exercise, boxing, and PD on the move. We have fantastic teachers, Yuri Milstein and Alex Tresser. I'm teaching one dance class. And it's 3 hours a week for men and 3 hours a week for women. And you can go to our website, parkinsonswellnessproject.org, and click on the workout page. We started this in September. We're going to keep going. Alex Tresser happens to live in Providence, Rhode Island. We have people coming from Mexico City, from Portugal, from different places, but we want people here. We have room for everybody. And it's helping everybody. And in this time when we're all isolated, as Anita can even say, her husband participates in our classes, and so does Rena's father. I don't know if Anita, you want to say anything, how it's
It's fabulous. It's fabulous. He enjoys it. He gets a lot out of it. Alex's class knocks him out completely, but he looks forward to it. We were worried when we were all confined that he wouldn't have a place to exercise because it's so important, but he loves it, and it's adorable. I love listening to it, so it's really great.
The men are bonding, the women are bonding, everybody's getting to know each other. So we do have that. So we're hoping that everybody will share that information with their professionals, their doctors, and send more people to us. I just want to say that we do have a lot of questions on the chat, and we do not have time to answer them now, but I will send them to our A team, which I think is our A+ team. A++, and hopefully we'll get them answered on our blog, which is on our website. So if you'll go there, within the next week, we'll have those questions and we'll be able to answer. So what can I say? I appreciate all your time and effort. I think it was great to hear all of you, and thank you so much. Just please, let's give an applause to everybody who joined us today. I appreciate you all being here, and I hope you all learned a lot today. A little parting musical interlude. We want to allow you to hear Arlen Bennett's World of Possibilities.
Great song.
If you can walk, you can dance. Talk, you can sing. Rock, you can roll, yeah, you can do almost anything. Yeah, anything. If you can think, you can dream. If you can dream, you can fly. Fly, you can seek. Seek and you will find the missing piece to the puzzle of your life, the one that disappeared just when things were going right. Close your eyes and you will see a broken world is a world of possibility. Yeah. Dealt a cruel hand by the master croupier. Don't seem fair, but Now you've got to play, so double down with an angel from above. Stand your ground and soon you will discover the missing piece to the puzzle of your life. The one that disappeared just when things were going right. Close your eyes and you will see a broken world is a world of possibility. Yeah, possibility. Ba-da-da-da-da. Ba-da-da-da-da. Listen now, if you can walk, you can dance, talk, you can sing, rock, you can roll, yeah, you can do almost anything. Think, you can dream, if you can dream, you can fly, fly, you can seek, seek and you will find that missing piece to the puzzle of your life, the one that disappeared just when things were going right. Close your eyes and you will see a broken world is a world of possibility. Yeah, world of possibility.
Thank you, everybody, for joining us today. I want to thank our wonderful panel, our wonderful family members. I appreciate all your time and all your wonderful thoughts. I think we're reaching a lot of people, and we're going to keep doing that. And we'll see you all November 17th. It's a Tuesday next time. Okay, we're trying out our Tuesday. It's in 2 weeks. We have a great program, almost as good as this one. After we leave the meeting, there'll be a questionnaire to fill out on your browser. We appreciate it because you're helping us help you. So thank you for taking the time.
Susan, thank you for everything. Thank you.
Thank you. Bye-bye.
Bye, everybody.
Take care. Thank you. Bye-bye.
Bye. Mhm.
Stay well. Bye.